And now we will switch to a talk from Dr. Jaroslaw Maciejewski from the Cleveland Clinic, who will discuss germline mutations in adult patients with MDS.
Yeah, thank you, organizer, for inviting me. Thank you, Steve and Moshe, for having me here. I think the topic is less controversial and by far more objective because we are actually measuring something and there is no make-believe as to, and you know, in my opinion, the inflammation is in this Bermuda triangle of nonsense, and we should really focus on genetics in MDS. I have nothing to disclose with regard. I do have funding from different entities. I want to start with a compendium of genetics in the context of germline alterations, a little bit about clinical implication and testing when, who, and how. So this is the outline. Now, you know, we started with genetic testing, and then increasingly WHO and other entities included objective genetic results into the diagnostic criteria. Originally, it was with core binding factor leukemias, where even if the number of blasts was decreased, was not reaching the criteria of leukemia, it was diagnosed as leukemia. But now we have a bunch of entities. I don't want to list them all, but many of them are quite common, including the one, the DDX41, that is probably the most common genetic inherited abnormality in adult patients with myelodysplastic syndrome and leukemia. Of course, Lifraumeni and many other WHO defined diagnostic entities that are defined by the presence of germline variants. Here are some more to be listed, and I'm sure there will be some added to it in the next future. Now, according to what I said, I think it is important to revisit the pathogenesis behind the predisposition traits. So, of course, you know, as we move in the age, the impact of germline should decrease, and the phenotype associated with the genetic presentations will be weaker and diluted by the impact on environment, versus somatic lesions would dominate the diagnosis of leukemias and myelodysplastic syndrome and other myeloid neoplasia in older folks. But which type of defects we have? There are many of them. They can be grouped according to different criteria, and they are overlapping. For instance, Fanconi anemia genes could be also grouped under bone marrow failure. So I think there is no point of arguing about it, but definitely they are these groups which sometimes define the panels which we use for testing. So, you know, in terms of the dominant traits, we have the canonical variants of known genes, and this is much easier to understand because these are the lesions that are typical. And then we have, of course, the other variants of the same genes, and this is where the conundrum is, whether they are impactful or not. So they are less pathogenic variant, I would call, of dominant traits. And in recessive traits, the big question is whether carriers of recessive traits are indeed affected, maybe at the later time point, or maybe only in form of incomplete phenotype, and the recessivity is not really absolute, particularly if we are talking about complex compound heterozygous with other recessive traits. So it starts to be very complicated. The other aspect of it is that genetic abnormalities that occur in the germline can direct what's going to happen to them as we move and as the disease develops. And one of the, of course, heterozygous germline variants or loss of function variants can be accompanied by allelic somatic hit. These are several examples of this that we know. Of course, hemizygous deletion and the somatic UPD, as we described many, many years ago for several of these genes, can be a way to to duplicate heterozygous variant and increase the impact of the resultant pathogenetic pathways on development of disease. The other way is, of course, that in terms of the dominant trait, we have a direct effect on disease evolution, as well as a recessive traits that are biallelic in most cases when they cause the disease. But usually we would expect that in this setting, the disease will present early on and has a stronger phenotype, so this would be more in the realm of childhood diseases. Now, the final word in terms of the pathogenesis that I want to mention to you is, of course, the somatic gene rescue as a general principle of leukogenesis that we more and more realize. And it is to the fact that certain genetic alteration present in the germline provide a pressure and disadvantage and prompt selection pressure in terms of the ecologic and evolutionary pressures to select for relieving mutations. And I think this is a general principle in myeloid neoplasia, maybe in other cancers too. We have observed it classically with severe congenital neutropenia and Elaine, where the loss of where the mutations are relieved by gain of function mutation in CSF3R. In Diamond-Schwachman DBSD, we have the 20q minus EIF6 loss of function, or TP53. And of course, I am still arguing that in certain cases of DDX41, the gain of function of DDX41 in form of a canonical 525 mutation, maybe it's not another loss of function, but it's a gain of function mutation. Definitely the genetic configuration would support it. So we have an impaired hemopoiesis that is not deleterious to the fact that it would completely alleviate the proliferative capability and therefore ability to pressurize the system towards evolution of clones that carry gross advantage above and above what the most of the cells in the bone marrow would have. So these would be the three, in my opinion, most important pathogenetic pathways behind predisposition in adult patients with myeloid neoplasia. Now, there were many studies, including those from our and other laboratories, showing that there is, if you screen big panels of genes that could be affected by alteration in germline and contribute to disease evolution or contribute to the risk of disease, we find here either in bone marrow failure syndromes or in myelodysplastic syndrome a large number of patients who will be carriers for these genes. And of course, the management of these might be quite difficult in terms of those that are suspicious VUSs or those that are not quite known to be pathogenic. But in any event, if you add together anywhere between 6 to 10% of patients with bone marrow failure syndrome and adult patients, and probably around 4%, conservatively speaking, would be carriers of predisposition genes, which might be by themselves important. Now, there is not quite the age dependence that we expected in this particular study, which is interesting. In another study, this is a study of 86 families with strong history of myeloid neoplasia from, I believe, France, whereby, as you can see, the most popular genes found in these families are listed here. In another study from our group, we would show that the compound heterozygous and rare allele homozygous are also relatively frequent in patients with myelodysplastic syndrome. This study was significant in as much it was not a somatic exome sequencing, but germline exome sequencing that was used with 690 patients. So this is a quite profound study in terms of the rigor of calling it. And of course, what are the diagnostic scenarios? The most common diagnostic scenario clinically would be that we order the somatic panel, and there are some genes that can be also affected somatic in the germline, and we found variants that are suspicious to be a germline variant, and then we face a conundrum to decide whether they are impactful or whether they mean anything. One could resolve it by applying then a specific panel or germline sequencing panel. The other scenario is that there is a strong clinical suspicion, clinical need, or there are potential clinical consequences. They might be not necessarily to the patient, but to the family, in which case, the germline panel can be ordered. We do it usually via geneticists because they are better for extorting insurance money to pay for these type of things. And plus they don't have to see so many patients, so they have more time dealing with this. But in any event, you could order a specific panel if you have an idea what it could be. If somebody has gray hair and age prematurely and so on, then you could order telomeropathy, or if somebody has, in addition to it, some other symptoms. I'm going to mention some of them. But if there is a strong suspicion that there is a genetic trait involved through family history, and we have no clues clinically as to what it is, of course, one could order the whole exome sequencing and other tests. Another advantage that the geneticist would offer you is decreasing the burden of proof in terms of the interpretation of those that are sort of ambivalent, and I am going to mention a few situations in a moment. So, if we have a history of patients with bone marrow failure or malignancy and personal history, family history of clinical exam, and imagine we are all physicians, or most of us are physicians here, so I don't want to sort of pound on it. It's a pretty basic stuff. Point out we have a choice of ordering any of the germline panels, and they are preferably done on sorted leukocytes, in some places on fibroblasts grown out of bone marrow or on skin. And one can order cancer predisposition, targeted panel, single genes if we have very good idea because of the family history that is well known that the family carries a particular gene, or we can order exome sequencing. Now, clinical features, many of the genetic predisposition can be syndromic, and there are certain configurations that more and more strongly suggest leaning towards one particular type of functional group of genes that can be affected. Here I listed few of them. GATA1 is one that is sort of very prominent, and of course telomeropathies provide a sort of, with pulmonary hypertension, with liver fibrosis, etc. is another one that might be very revealing in terms of what to order. Now, what do we do with, in terms of the diagnostic algorithm? There are certain hints for the practicing hematologist who sees coincidental genetic abnormalities that may be of germline origin. Of course, the known canonical alterations are easy to deal with. The high VAF and low MAF in controls is another hint, but it's not absolute. And there are studies here, for example, this one from Spain, showing that there is, if we go by MAF of lesser than 2% and VAF of greater than 40% in likely pathogenic variants, then we are going to be correct by doing germline testing as revealed by germline testing, only in 65% by predicting that this is germline alteration. This can be a large clone, or it can be something else, or can be an artifact. This is a quite interesting study that I want to point out to you. But in any event, the impacted variant, canonical pathogenic variants of dominant traits, biallelic pathogenic variants, but of course, if you look at somebody who has DDX41 somatic mutation, but this person has DDX41 140 frameshift mutations that we originally described many, many years ago, then it's particularly suspicious whether the other hit is actually impactful, irrespective that it could be a VUS. Because, you know, the idea that you have a biallelic setup with a canonical germline variant is very unlikely. Now, other variants in clinical context can be also, the clinical context might give you clues as to what to do. So, biallelic configuration I mentioned already. Now the caveat to it is that the intronic alterations such as in GATA2, ANCHOR-D25, and there are certain mutation in the promoter of TERT that if we have only exome sequencing, we are going to miss unless you target them by a specific single gene panel. But these are rather uncommon and maybe sort of in the realm of specialty. So we can identify suspicious VUSs, likely pathogenic variant, predict that they might be of germline origin, and then the confirmation would be germline DNA testing. Again, this is probably rarely done. In most of the circumstances, we would be able to make a pretty good decision whether this is a germline variant, and depending on the gene that is affected, it would be clinically impactful or not. This is from Carmelo's papers that I forgot to quote, but you know, the paradigm has been that genetic alteration would cause early disease, but you know, our study in DDX41, and I recall vividly my stress 15 years ago, where we identified the DDX41 mutation and tried to submit it to every journal known to men that rejected it. Finally, the study ended up in cancer, in stem cell. One of these journals, and we were so relieved that we finally get it to public, and now we believe that DDX41 is one of the most common adult germline predisposition traits in myeloid neoplasia. So young presentation age, strong history, history of recurrent cloning, blood counts, preceding presentation in childhood, syndromic features are sort of highlights of what we should think in terms of the germline testing for predisposition to myeloid neoplasia, also in adult patients. The other factors that might play a role are implication for family planning. I mean, if somebody is a single 80-year-old male who has leukemia, and you know, the question is, how it would affect family is clear. It might be less important than somebody who has large family and there is a lot of kids and uncle kids, and some of them might be overtly anxious about whether there is a gene running in the family. There might be possible need for monitoring and prevention, and there are certain therapeutic consequences, and I'm going to, in 30 seconds, mention some of them. So clinical, once more to clinical clues: brittle abnormal hair, premature gray hair, unexplained personal history, for short telomere disorders, immunodeficiency, or presence of chromosome 7 abnormality in GATA2, SAMD9 disorders, history of thrombocytopenia and bleeding in platelets, familiar platelets disorders, biallelic BEP1 alpha. We think about this single first hit being in the germline in CBP1, and history of other cancer, or hypodiploid ALL in TP53 and Li-Fraumeni syndrome. Special cases The risk of progression and transformation might be very high, from 80% in CBP1 alpha to rather low. It's still high in males at 25% in my favorite gene, DDX41. The routine brain magnetic resonance imaging and some other things may be deployed in certain cases. POT1, it would be an example for it. In lymphomany, of course, monitoring for other cancers using whole body MRI or CT scans as a surveillance, referral to ENT, liver, pulmonary workup for telomere disorders. Another special circumstance is, of course, a case of bone marrow transplantation, whereby both the recipient as well as the donor might be subjected to a scrutiny as to whether we should screen for germline variant and think about it. So family history, and of course, in strong family of cancer or leukemia would preclude us from using from using a sibling donor. And original discovery of that mutation happened this way: that the patient with aplastic anemia was transplanted from a brother, I recall, and never recovers the counts, and then the third mutations were found in this particular patient, opening the whole field. So we have to think in terms of matched sibling donor selection and avoid it in strong suspicion or prove that patient has a hereditary syndrome, as a predisposition syndrome. And the other issue is, will a patient be able to receive the normal conditioning regimen, which has to be modified? And I just wanted to exemplify it briefly by a study here by Kuhleman, who showed that many that carriers of telomeropathies, particularly third variants, that are inadvertently found in patients with myeloid neoplasia that were transplanted, the carriers themselves have higher risk of comorbidities during transplantation. So this is not only that they got a bone marrow, it's not that they got the bone marrow from somebody who was TER2 mutant, but of course the TER2 mutation or alteration is present in other tissues and predisposes to complications, decreasing the expected survival or outcome benefit of transplantation. So, and my prompt to modify conditioning regimen so that it's less toxic. So, discovery of germline alterations might have important clinical implication, establish diagnosis, sensitivity to chemotherapy. This, of course, Fanconi anemia is an example. A selection of donor for hematopoietic stem cell transplant, conditioning regimen, consequences for monitoring, implication for relatives. A certain germline variant have clinical prognostic implications. So I do believe that we should think about it, and even in adults, suspicion-based approach is, I think, most reasonable. There is no reason to overthink it. It may algorithms that might change when we discover the next gene. Remember, patients in whom we originally found DDX41 were completely inconspicuous in terms of the presence of germline predisposition. Use of targeted germline panels for discovery of suspected germline predisposition may be needed, and the consequences of heterozygous carriers and non-canonical variants carriers remain a challenge. Thank you very much.
Thank you.
Thank you for the excellent talk. Unfortunately, we don't, well, can we take this one question? Let's have one question.
Yes, no question.
Okay.
Yes, no. So CBP alpha germline, do you recommend transplant first line?
It's a yes or no question.
Of course, from unrelated donor, yes.
Thank you.
Thank you.